Hello students, today we will discuss a very important X-ray in your exam, especially it will be kept in Oxy in your final year surgery exam, and instrument in X-ray discussion also it will be shown as such. What is this X-ray and what is the finding? Just to go through that. Chest X-ray with the abdomen erect posture. That is the point you have to tell always. Remember chest X-ray, not just abdomen. Chest X-ray with the abdomen erect posture, not just a plain X-ray abdomen erect posture. It is a chest X-ray with the abdomen. This point is important, with the abdomen in erect posture. Only plain X-ray abdomen, if you say, they may miss the diaphragm, because chest and upper abdomen should be seen, diaphragm should be seen. So there is a chest X-ray with abdomen in erect posture. So finding is gas under diaphragm. So this is the finding which you have to always tell in the exam. And you see that this is the diaphragm, this is the white line is diaphragm, this is the air column, this is the air column. So naturally liver border is here. So diaphragm is here, this is the air column here, and this is the liver border. So that's how exactly it comes. And gas under diaphragm, this is the fundus shadow. There may sometimes gas shadow on the left side also, but mainly right side we are always look for the gas under diaphragm on the right side. Left side sometimes will be there above the fundus shadow. But site is, this is the site you have to see, diaphragmatic line, white line is the diaphragmatic line. So suggests hollow viscous perforation, maybe anywhere. Duodenal ulcer perforation, gastric ulcer perforation is very common. Then small bowel perforation, maybe trauma or typhoid perforation, ileal perforation, sometimes tuberculosis, amoebic, gangrene, so many perforations, or colonic perforation, so many perforations. Remember, appendicular perforation can occur, but it doesn't cause much gas under diaphragm, because so gas leak is very less in appendix perforation. So gas leak may not be there. So commonly gastroduodenal perforation. It can be small bowel, colonic, like rightly told. So causes may be peptic ulcer perforation, trauma, malignancy, ischemic, typhoid, volvulus, intussusception, tuberculosis, stricture in the bowel, ulcerative colitis, Crohn's disease, even congenital conditions in a neonatal period, in children, also different causes may be there. So all these conditions you have to remember. So CT scan is ideal. Once you do that, it's very typical. X-ray is very typical. There is a perforation. Surgery is the treatment, nothing less than that. Remember. So this is the CT scan findings. See that? See that this is the liver. This is the gas. You can see the gas here. Very nicely seen. So CT is ideal. Usually plain CT is done in this patient, not contrast, because patient is on nil oral on rice tube with the catheter, IV fluids. Because initially you have to do resuscitation, then you have to treat them by surgery, by emergency surgery, laparotomy, then go find it, identify the perforation site, then suture the perforation, maybe after taking biopsy sometimes, usually interrupt the suture, usually either polyglactin, vicryl, or using silk suture as such, interrupted suture always. So in this patient it was pre-polygastric ulcer perforation. So Cellar-Jones technique is done. Cellar-Jones technique is place the suture, usually 3, sometimes 4 if it is very large. Then place the omentum, don't put the knot, place the omentum over that. Place the, if this is the perforation, take bite 1, 2, 3. Then place the omentum like this. Then place the knot. Place the knot. So then put the knot over the omentum. That is called Cellar-Jones classical technique. This is what is commonly followed. This is what is done. Perforation is here. See that omentum is placed and it is sealed, closed. So CT is very clear. So remember also, Chilaiditi syndrome is the interposition of bowel between the diaphragm and the liver. So it's a plain X-ray shows like a gas under diaphragm. So it may be misinterpreted and surgeons may open unnecessarily. So that point you have to remember, differential Chilaiditi syndrome. It is often asked as MCQ, remember. And Valentino syndrome also, because think that clinically present as appendicitis, so somebody does appendicectomy, but actually it is a duodenal ulcer perforation where pus trickles along the right paracolic gutter, present as a pain in the rectal fossa, and it is a perforation may be missed, and patient may die of peritonitis because you have removed only appendix without identifying the perforated duodenal ulcer. So that is called Valentino syndrome, which you have to remember. And Rose-Grum's operation, you have to, what you have done is not Rose-Grum's, Cellar-Jones. Rose-Grum's is close it and put the omentum actually. Modified rose gum therapy, again similar, little different. Herman Taylor, old people, early patient, within 24 hours the patient comes with the perforation. If leak is very less and patient not fit for surgery, you can start IV fluids, place the right tube at decompress bowel and pass a catheter, maintain the urine output, give good antibiotic, and you can treat conservatively but with the monitoring. That is called Herman Taylor's regime, not in every patient, selected individual as such. So later anti-ulcer triple drug therapy is important. Once you have done the closure of the perforation, especially for gastric and duodenal, mainly duodenal ulcer perforation, you have to do gastroscopy after 3 months, and you have to give the triple therapy, anti-ulcer triple therapy to this patient to make the ulcer to heal completely. So gastroscopy during follow-up is very, very important in this patient. In duodenal ulcer, remember, anterior duodenal ulcer perforates, posterior duodenal ulcer bleeds. Anterior duodenal ulcer less likely to bleed. Posterior duodenal ulcer is a retroperitoneum, unlikely to perforate. So anterior perforates, posterior bleeds. That dictum, that quote is you have to remember always. So follow-up gastroscopy later in 6 to 12 weeks, and anti-ulcer therapy, including either pantoprazole or omeprazole or whatever your choice, should be given in this patient. So students, remember, first very commonly kept X-rays in oxy or in X-ray during your exam, practical exam, is gas under diaphragm, very commonly kept. So I have detailed everything about that. Read my clinical book, it contains X-rays. Read SRB manual of surgery for detailed gastric ulcer, duodenal ulcer perforations and different conditions. You can read operative surgery, and you can go through my in detail video lectures, digital through JP Publishers. You can subscribe, and entire surgery video lectures are there from A to Z. Always you can subscribe and go through that for your final MBBS exam. Thank you very much. I hope you understood well.